especially amongst the Catholic-based groups, and I've said that running a health institution requires people who can manage it as a business and not only manage it as a center of faith, and that it doesn't have to be Mother Superior. They have sometimes taken fault with that, but I really mean it. That just like we waste the surgeon to be a medical superintendent when he can't manage, we cannot waste Mother Superior or the priest to be the one managing these things. Let's be frank about this thing and say that there is an efficiency model that can bring in not less than the 40 or 60% that we're wasting at the moment. And that is money that we already have. And I would say that living here, that is a model that we ought to all be starting looking at. How do we use the pennies that we have, if they are that scarce, better? The second model is the PPP model. In the last 5 years, I've been assigned by the World Bank Group, IFC and the World Bank, to work with African governments and entrepreneurs to create an enabling environment for more investment in health and bring in the non-state actors to be on the same table, round and equal with the government. And I have worked across the continent on this. And I've had some very, very interesting experiences. One is that when we start looking at non-state actors, which we look at both the faith-based, not-for-profit and the for-profit ones, there's a tendency for the faith-based one to say we are different, we are not like them. And yet, for the government, they're looking at all of you as non-state actors. Two, there's been a tendency from the faith-based to tell me that we are already talking with the government, we don't need better dialogue. But then when I come here, the first thing that I'm hearing, being challenged by my sister in WHO, that nobody is recognizing us. So you have to be truthful to yourselves. The very, very fact that you've had a long history of engagement with government and signed these MOUs doesn't mean that you have a productive relationship. And when I read the MOUs that you signed all over the continent, they're probably some of the most useless documents that anybody who is thinking of contracting seriously in health would do. But you're very happy with them. Maybe it is a matter of faith. But these things are now legal, they are contractual. And we have to change the contracting completely and redo the PPP arrangements that we have. Because you are private sector, they are public sector, and you need a relationship. That means that everybody keeps to their own words. That will mean that rather than a government coming in and finding that you are in Karamoja or in Turkana, like Dr. Dongo has just been telling me, and finding that you are the only one providing care there. So their solution is that next year we will build a hospital next to yours. The solution should be, you are doing there so well, why don't we give you more money to do more and do better? If your MOUs cannot do that, then forget about them. You're wasting everybody's time. And yet this is exactly what's happening. So you end up then with two institutions, one faith-based struggling, and a government one that is built next door, a beautiful building with no staff and no services. And this is the picture. If you went and took on the satellite picture of Africa, you will see this all over the place. And you don't have to do it at night, at daytime, you will see it all over the place. So that model is a model that has to be expanded and be done better. The fourth model is the health insurance model. Africa is into the decade of health insurance. And we're all struggling, every country, to put in place some form of social insurance. Yes, there are nasty political things, but the discussion is going on. And they're beginning to expand. It's no longer just Rwanda or Ghana. Kenya is expanding, and in fact, in probably another year, we'll have more than 60% of this population in Kenya here covered by NHIF. And it's happening in Tanzania too, where they have started. It's happening in every country where we are working in. And I know it's Nigeria and everything. But then, you seem to avoid the discussion in this area. You are not on it. So you are happy sometimes because you are not for profit When people say there is free maternity services, you say that's the best thing, even if it does not deliver anything. You saw Dr. Kolongo's slide, free maternity services in public institutions. That doesn't include you. Why are you not in that? It's because simple. The government of Kenya is rewarding every public facility for every delivery done, but not the faith-based one for every delivery done. Now, you don't have to go to Harvard Medical School to see that there's something very wrong here. And why are we allowing it to happen? Where are we in the dialogue? And why aren't we thinking of a model that says that the woman has a right to deliver where she wants to? If this country wants to give every woman free delivery, then pay for every place where this woman can deliver safely. But fix the cost and do it. That's a decision, and we've met with the Ministry of Health, and I hope that they're going to be doing that in the next few months for that to happen. That's a model that we have to start looking at when we start looking at health insurance and how it helps us. Without health insurance, all these non-state and even state models that we have in Africa are all going to be where they are. They will not grow. The fourth model is, for want of a better word, I'll call it the external, or not external, but donor-supported model. That was the advent of the faith-based institutions in this continent, where in the days when people used to build churches in Europe and America, there used to be quite a bit of collection and money that came into Africa. But now if you go to those churches, you will find that they don't fill up anymore. And when they do, they're people my age or older. So the well is drying up. But then in this model of donor, we still have in Africa tried to see donor as being somebody who is outside of the continent. Philanthropy is color-blind. And we are now in Africa seeing people who are as rich as everybody else in the world. To the point that when we challenged the Nigerian ones in the work that we're doing in Nigeria, Daliko Angote gave $20 million on the go. Here is a check for the private non-state actors to do their thing. And Daliko Angote is not unique. They're there. Some of them come to church. They may not believe in the preaching, but they do. But then we are only going to them with this small little bag for them to put in 100 shillings, 200 shillings, and we are not meeting them in their offices to ask them that there is a bigger mission where your money can go. And we are burying them now in Africa here, that first generation of rich people. And a lot of their money is in Swiss banks. And none of you is talking to them to say that that money can actually be used in a foundation here. And those foundations can be faith-based and can be managed better. Those four models are models that I want you to keep in mind, because what you've worked on so far, where somebody comes from somewhere to give you money, that one is gone. Now moving from that, we start asking ourselves, where does the bigger money that comes from the World Bank and other bilaterals sit in? For those of you who are in maternal and child health, you will recall that since 2000, the year 2000, there has been a struggle to create financing models or financing resources for maternal and child health. A lot of these globally have come in through special initiatives, like the HIV/AIDS initiative that we have in the World Bank. We now have the Global Fund, and we have several funds. And there have been a lot of discussions, Miriam, you are in UNFPA then, on whether there should be a special initiative or a funding bank for mother and child, because UHC for us in Africa starts with the mother and child. If they are not in it, then you don't even discuss it. And over nearly 15 years, I've been involved in that until fairly recently that came up this issue of the Global Financing Facility, GFF. How many of you have heard about this? How many of you have participated in asking where it's coming from and where it is going and how it helps the faith-based groups? This is why it started. That yes, we have had some momentum through the MDGs to 2015, and it has made some difference. There are people at the beginning who are very, very skeptical and saying, we'll never reach those goals, so why try it? But there are also many people who say, if you don't try, you'll not go anywhere. And I think that we have gotten somewhere. But then, the agenda, as we are in 2015 now, just like we were in the year 2000 for Health for All, is unfinished. And it is unfinished for reasons that we are showing you there on the slide. The gaps are still there. The sustainability of the progress cannot be guaranteed. There's still these inefficiencies that we talk about. And there is, for our countries, the whole issue of getting the right data, the baseline data that comes out of registration and so on. And the big issue here is not so much how much comes from outside, but how much domestic resource is there and how much can we raise for health. This is coming in at a time when Africa has never been more endowed with in the extractive industry area. Fine, the oil prices are down, but there's all other minerals that are offered. And in fact, our figures are worse in health for countries that are more endowed with these resources. But then, when we talk to the companies and the people who are there, what do? We go for the small little things with them. We don't go to the big companies and say, can you put big money and work with the faith-based in this particular area? No. Small little things. You go to Shell, and I don't know whether you have met with Shell as faith-based organizations and asked for something that's really big and transformative, rather than getting the few pennies that people get from there. That's not happening. The GFF then is therefore part of a broader global effort of financing for development. And this is an effort that we must all be in, because we in the health sector have the habit of thinking that we are so different and money will just come. We are part of development. And that's why we do not even participate in the discussion in the ministries of finance, because we think this is not where we go to be. We are part of that. So that then is where this GFF issues come from. The ultimate goal of this is already written down. And these figures that we want to reduce will not happen until this continent wakes up and makes a movement, and until the parts of this continent where you provide care get to spend these resources efficiently. And I repeat that, until the parts of the continent and the populations that you serve are reached, it is not going to be possible for us to do this. I make this as a statement to confirm to you that you are much more important to this global effort than the global effort is to you. And it is up to you to make sure that you stand up, you are not threatened by anybody, and you are there and say so. That if we don't give this service, because we are the only ones who have done it for those years, we can scale it up quickly, it is not going to happen. Then we are going to be missing on the road. The key focus areas are the ones that you have there. Mobilize and channel additional international and domestic resources required for scaling up. Because what you're dealing with is not just sustaining what you have, but scaling up. Then long-term sustainability, domestic financing, extremely important for us to be able to move forward. And then the civil registration. The countries in the world that have some of the best civil registration, I get an example of the Scandinavian countries, actually started it from the church basis. The mobilizer for registration in this continent can never be better than the church basis for it. So when we start talking civil registration, please do not feel left out on that, because you are an important part and can play even more that's out there. The commitments to date, that's where it is. And it may look a lot of money in those figures, but in 5 years' time, this money will be gone, and you will not be part of it unless you insist that you are part of it. Because it's very, very easy to spend this money without it reaching the people that you must reach and that only you can serve. Now, what is the operating model that the GFS is putting on the table? That is essentially the driver of the overall GFF approach. And you can see that there is SMART. It has to be sustainable, and it has to be scaled up. And that smartness is key to moving forward from where you and everybody is right now. That scaling up is an absolute, because we are all doing far too little at a time when we need more, and sustainability is important. Because unless you have predictable financing, you cannot scale up, and sustainability will be a problem. The two graphs there gives you a sense of where we are right now in terms of the way we work in this sector. With the government putting in some, donors putting in some, the private sector, everybody putting in that, but we are not covering that circle universally. And this is not a money issue, it's a model issue on how we can do differently. The Minister of Health told you in the morning that in Kenya, the donor funding, 65% of it is outside of the budget. So if you ask them what it is doing, they will not tell you in any detail. Nobody is saying it comes to the budget, but everybody agrees that the planning ought to be done together so that we know where that money goes. And this is what GFF must do and do differently. The rigorous data basis has to be there. There's too many things that we do in faith, but we do not monitor. So the hope is that with vital registration improving, we shall have a population basis for what we do. I'll give you an example, and let me give you an example of what the Minister of Health has just presented here this morning. Free maternity care has come in. The number of deliveries in institutions has gone up by X percentage. Conclusion, if it continues this way, maternal mortality will go down. Does it make sense? Will it necessarily go down? But that's a good political statement, but not a good technical statement. Because you want to ask, who are these people who are coming in? Where were they delivering before? Were they going to faith-based, but they're now coming to the government ones? So they're already delivering in a place where they would be safe, but they have shifted. Are we really going down to get the people who did not have antenatal care and so on? And then we're measuring people who deliver here. But we know that delivery alone is not enough. There's antenatal care and postnatal care. Did they have antenatal care? Will they have postnatal care? Data has to be in there for us to be able to move this to the next level, because we are scientists above everything else. Now, scaling becomes an important for the 2030 targets. And if we are not scaling, then it won't happen. And I want to put it to you that you should insist that that scaling is not just done in terms of the national data, but done also in the desegregated data. If the faith-based non-state actors in Africa are not scaling up, then that scaling up is not really happening. Because public institutions on their own cannot handle the workload that is needed for this to happen. We know it. And definitely, even if they were to do it, they cannot do it within a year or 2 years, because they don't have all those facilities to set up. But your facilities, some of which are working at 20% bed occupancy, and you have staff there, it will be much quicker to get them filled up with people who need this care because somebody is helping pay for that than building new ones and moving forward in that area. So scaling up has to be seen in that particular context. Now, the resources from the World Bank, where are they coming from? Is IDA, because we're focusing on the 63 countries of lowest income and with all the problems that are there. Nearly each one of them is in Africa. Nearly each one of them is one of your countries. So this is where we are in terms of that money. There's trust fund money, but there is also money that is coming in. Unfortunately, the World Bank, just like WHO, comes in through government. And you will ask, why don't you come through us? But you are the ones who have created this international infrastructure. If we come in through government, do we reach you? Are you part of the health dialogue in your own countries? Is it enough because you signed an MOU that when this thing comes, that MOU will be remembered? This is why we've been struggling to restructure this sector so that a minister of health in a country does not see himself as a minister of the Ministry of Health, but a minister for the sector. And that sector, when you look at it in terms of who's spending money there, who's being treated, who has a facility, that sector is mixed sector of state and non-state. So as a minister, that is what you do. In the last WHO regional meeting, or one of the previous ones that I attended, I had asked my fellow senior ministers for health in Africa, which one of you feels that you're minister for both the public and the private sector? And only 3 put up their hands. That the non-state actors are not under them. So when the World Bank or WHO come to talk to us because those are the people. It is not them or us if they're providing the data. But when they give the data of health outcome in the country, 55% of which come from non-state actors, they very readily take the whole of that data and say, this is what we have done. This is where the dialogue has to change, and this is where you have to come in and come in strongly. Now, scaling up means also efficiency. Pooling and sharing. There's too much overlapping in the things that we do. It's not just overlapping between public and private. It's not just overlapping between donors, but it's also overlapping between the different faith organizations within church. So this one is Presbyterian, and this one is Anglican, but they are next to each other, and they are fighting for the same patient group. Now, God is one. God is one. And if this same God is watching what you are doing, then I'm sure that is telling you that surely, even within us, we can do better in terms of pooling our resources and moving things forward together. This is exactly what you have done very, very well in this region with MEDS, serving all those ones there. And we can do it also in the area of facilities. We can do it also in the area of employing some staff. Give you an example, and I gave it yesterday. Consultants working in your hospital. If the Anglican church next door has a surgeon, surely that surgeon can also operate in the Presbyterian hospital over there. Because you can't keep a surgeon busy in just one place. And you can share the cost of that surgeon. So we have this FBO surgeon who's serving this region, who's paid by all of them, so that we can all afford this person, rather than each one of us working towards that. Then there is also the issue of new partners. And those new partners is a challenge that has to come through all these models that I started with. And those new partners must be partners who are interested in the performance that is done. And for us in Africa, I believe that the most important new partner must be the Africans themselves. The Africans who have made it through hook or crook They have the money. We've got to bring them to repent and give some of this money. So, where is that effort? I want to see that effort coming out of there, that we are reaching out to the 20 richest Africans to work with the church to make a difference for women and children. If you need help in that, I'm willing to give you help on that. And my institution will be giving you help in that, because we know them, we know where they are, and they actually mean very, very well. And they'll feel gratified that somebody is trying to recognize them to use that. Those new resources must also come in the area of the kind of national mobilization that's there. There's been a lot of talk on taxation. New forms of taxation. You heard about the airline tax, where we were saying every flight to Africa, there must be some few cents that comes to the health sector. We've talked about the money transfer tax, because we have a lot of money from the diaspora coming in, that if everything, that the Western Union and everybody, there was 1 cent out of that, there would be enough money on it. Then there's also been the sin tax from alcohol and tobacco and everywhere else. Do you support that, or do you not support that? Can it be driven to help this continent move forward? Now, sustainability is going to be the key. And I see sustainability as being more locally grown resources and more local efficiencies. Two things that you must do well in each and every model that you want to work on. And that means too, that as the resources go up, we have to start asking ourselves, what is the cost of healthcare? I've just been doing some analysis here in Kenya, and we have found that Nairobi is one of the most expensive cities in terms of health. The cost of healthcare in this continent, everything given, is amazing. It is so expensive that the health workers themselves cannot afford to be treated in the facilities in which they work. You look at it from the inputs that we have in there, whether it is medicine and so on, which we keep taxing even for essential medicines and putting all the VAT in it. You look at it in terms of the salaries that are in there at certain levels, and you look at it in infrastructure. Right now, it is cheaper for any African to put his own family on Kenya Airways, plus their grandmother who has cancer or whatever it is, and go to India for 1 month and come back with full treatment, than it is to get that person to be treated in Nairobi or in Dubai. There must be something wrong with the model of healthcare that we have here. And the model of the healthcare that we've had here is a model that serves a few people who do not want to be treated here. It's never been a model for the people who want to get care here. To the extent that now, the healthcare is driving the airline industry in Africa. There's been a lot of growth in the east-west flights. Kenya Airways, Ethiopian Airlines, Turkish Airlines coming on board, Emirates, Qatar, they're coming in. 1/4 to 1/3 of their passengers are sick Africans who are going into the Middle East and to India for treatment. Nigeria, my favorite country, last year, you sent 30,000 Nigerians for treatment in India at a cost of $1 billion. East Africa, you send people to India, smaller numbers, and that cost to $1 billion. And you're asking that we do not have money to take care of our own people. Sorry, my pointer has gone down here and the batteries are off, so you can switch there the next one for me. So the thing that I would like to work with you on is in this area. Sustainable incentives for domestic resource mobilization. Is there something that we can do together with the faith-based, with the World Bank Group, to start looking at what we can do locally in terms of the formal side and providing the capacity here for you to do it on the informal side for us to do that. But beyond that, this is the way we should do. Let's look at ourselves as part of the countries that we are in and ask what kind of taxation, if at all, will help us raise more money. Let us start looking at philanthropy as colorblind and let it start from the base. Let us start looking at health insurance beyond community-based health insurance, where you have done a lot of work, but where, unfortunately, sustainability is a problem. Let's be leading in the dialogue and crying for social health insurance to run. Inefficient it might be, but let's deal with those inefficiencies. And let us look at the business models. And one that I'm thinking of. Could the faith-based institutions, with all the facilities that they have, form themselves into a social franchise? Let me ask Kenyans. A few years ago, when NHIF wanted to contract with institutions that could provide multiple centers of care, they ended up with Meridian and another one that didn't have the facilities that you had. Suppose you went together as a franchise and say, we can actually provide this. Those billions would have come to your pockets and you'll be the ones running it. But you're too divided and probably too proud to think of that. And I'm talking of social franchising because I believe that even when you're not for profit, you're definitely not for loss. And if the only reason why you're in this thing is for loss, then you just won't sustain it. Some of the most viable health facilities in this continent that we go to, even in this city, the Aga Khans, the Nairobis, the MP Shahs are all not for profit. But they know that they can make money from somebody who has more money and be a Robin Hood to spend it on people who have less money. So being Robin Hood is Christian. And we have to start asking ourselves why we cannot go there, because only in doing so shall we come up with the smart financing which we need, which has four things. One, it must be predictable. Two, it must be extremely efficient. Three, it must be scalable and sustainable. The World Bank Group, myself in particular, will be more than happy to work with the faith-based groups in Africa to make this happen. Thank you.
I wish we had more time, but because of the limitation of time, we stop it here. Are there quick two questions for Professor Roger as we prepare for the next presenter? I've seen two hands there. Our sister there. Please speak to the mic and ask your question.
Thank you for a very interesting topic on healthcare financing. Just as Marek from Kenya, and speaking about the experience of the national healthcare universal coverage with a 10-year history of from 2004. I remember when the National Health Insurance Fund came seeking to contract faith-based hospitals with three levels of contract, one for the private hospitals, one for the FBOs, and one for the government facilities. The drive really for that was like almost one-sided dialogue with the NHIF preparing contracts ahead of time without any discussion at all, and without any bearing to the costs which are being incurred to the health sector, and driving that in a way that is completely devoid of dialogue. And so my comment is really, this is timely dialogue to really engage in what does it cost, what is available to reimburse, mothers when they come and deliver in FBOs, because it can be done, but the dialogue is not working properly. That's the comment.
Any other question?
Hello, thank you for your presentation. I was very intrigued that you talked about the GFF. We know that there was just a meeting in Kenya a few weeks ago, and we know there's upcoming meetings in Ethiopia and DRC. But as far as we know, no faith-based organizations have been invited to participate in those meetings. And I'm just curious if you have any role in ensuring that FBOs will be included. Thank you.
Thank you very much. We are not sitting from Zimbabwe. I think this has been an eye-opener, and we feel like we're best positioned in the way to realize that as faith-based organization, we are still naked in terms of getting where we're supposed to get. But I would like to propose maybe to say that I think if we have people like yourself as advisors to the FDO or to the CHARS, it will help us a lot to move forward, because there's so much information which we don't have, which we could actually build on. And for me, the presentation really opened a lot of avenues and new ideas to deal with. However, I also want to go back to our boards, management boards. Some of them are more faith-based or religious leaders, and sometimes when you come up strongly, they might think we're going against the doctrines, and what we need maybe is to have the capacity to look into the governance of a faith-based organization and building our capacity to actually operate at a different level. Thank you.
The last hand here from, wow, too many hands now. One here.
Thank you. My name is Jonathan Kiliko from NETS, and mine is to thank you, Prof, for the nice presentation. And I do believe when passion works together with skill, you get masterpiece. So with this world of experience and also interacting with the public sector, how can you work together with these faiths? It's a challenge you to us, that you can hold the hands of these ACHAP members to realize more impact in Africa.
Very quick, the last two hands there, seen. Yes, please. Yeah.
Well, thank you so much for frankly talking about the issues that we really, in our hearts, know but don't want to talk about, i.e. MOUs. The question is, how can we practically interface with this organization?
I think you can respond to this.
One more.
Thank you, Prof. My name is Pascal Manyoru, NETS as well. You mentioned something about the faith-based actually working closely with the government and not having what you call agreed deals and cases used as MOUs. And that also takes reference to what the chair of ACHAP, the challenge she posed to her excellence there. You know, it is very difficult sometimes for the faith-based to engage the government of different countries, because, as you mentioned earlier on, when results are positive and statistics show that we have a lot to showcase, then the faith-based brought in. But otherwise, we are put up with the equation. You people who, yourself, for example, working close with the IMF and World Bank, you have a lot of muscle, and the government will very willing to listen to you. My challenge probably would be, how you can help us, is when engaging the various governments, why don't you challenge them and say, to what extent are you engaging the faith-based? We see, for example, in Kenya, we talk of between 40 and 45% of the health care provided by the faith-based. Now, when you are actually discussing the government, because it's worried about the government interactions, why don't you bring the aspect of saying, asking the questions, how much are you engaging the faith-based? Why don't you actually engage the faith-based? Make sure that a facility in Uganda existing for faith-based is not put together, close to another one built by the CPF budget just because of political thing. So we also think that you can go a bit more than you're doing at the moment by actually telling these governments and ensuring that they work closely with faith-based in policy and many other areas of operations.
Could you just respond to those?
Thank you very much. I do have some documents here that I carried with me as a sample of what information we have in the country. We have the Red Book of the Business of Health in Africa. I know the moment one business comes in, you people think that somebody is making money and going anywhere with it. No. When you're running an institution, it is a business. You have a book, balance your books, see what's happening with non-state actors. 2. You have this blue book called Healthy Partnerships. It looks at all the 50-something countries in Africa and gives you an idea of how much governments are engaging with non-state actors. It is horrible. And a lot of these are countries that have signed MOUs with you and you think that you're doing well. There's money there that you could be using, but it is not coming to you. Somebody asked about NHIF. We've done a lot of work in this country on NHIF and the dialogue process that's there. There's a whole document here that would benefit you called the first ever audit of NHIF and setting up the dialogue processes that are in there. There's a lot. Some vendor will tell you how much work we have done in this country to try and bring this dialogue process working. PPD, public-private dialogue, is a key area for us to be able to move forward. So we can take that one offline and I'll be able to give you a sense of that. GFF, yes. The first 4 countries of GFF priority are Kenya, Tanzania, Ethiopia, and DRC Congo. So if you are in any of those countries, please wake up to this thing happening. The meeting was in Tanzania, I believe, a week ago. Kenya, it was there, and the faith-based groups, I believe, were invited. The question that's here is, and this is a rhetorical question, when we arrange this thing with the country, with the ministries of health, and with the partners who are on the ground, to what extent do your government view you as real partners, so that we cannot go there alone without you? You know, in the African culture, if you are going to pay dowry, there are some friends of yours who are so close you must go with them. You cannot go alone. How come when our Minister of Health are discussing funding, you are out? When they're discussing service, you are in. This means that there is something very, very wrong in the relationship. You are not real partners, and we have to work on that for us to be able to move forward. With the MOUs, we are working now very, very closely with ministries of health and ministries of justice in turning this around. MOUs were things that were conveniently done by the Ministry of Health without involvement of the legal aspects of it. So they are non-binding. And we are saying that if you're going to go into a proper PPP, where humanities change, staff change, and so on, it has to be legally binding. And this is now going to be changing all over. If you're in Kenya, you will see that. If you're in Uganda, we're doing the same thing. Unfortunately, we're getting the biggest resistance from the faith-based groups. Because they're the ones who are saying we already have an argument that we've been together for the last 50 years. And this acceptance that what you have, yes, it was good when there was nothing. But for where you want to go, that journey takes more than an MOU. If you accept that these documents are not as thorough as you want them to be, then in Uganda, in Kenya, in all these countries, we are able to work together with you to move this agenda forward. I do not know if I will answer anything more. I appreciate your comment from Zimbabwe on the management boards. My bishop is here. He knows that this is something that must concern all of us, that they should not be running these things efficiently must not be seen to be antichrist. And it's something that we have to get right. Because when they run well, then you give the best image of the church and the institutions that we represent. I do not think I can answer all of them, but I will be available through this session to lunchtime for any further discussion. But the organizers also have my contact from the different countries. I will be most happy to help you link with our colleagues in your own countries and for us to be able to move forward together. The government can't do it alone. You can't do it on your own. The donors can't do it on their own. But we have to work together to make UHC a reality. Appreciate it.
Big hand for Professor. Thank you very much for gracing us with your time and this presentation. I will receive these resources. They'll be available so that those who want to see them. And I'm sure we can get more from the World Bank. Professor has been a very passionate advocate for public-private partnerships. I can attest to that. He has really helped those of us in this country to drive that broader partnership agenda. I now want to hand over the session to our next moderator. Unfortunately, sorry for taking a lot of your session's time. Rick Santos, who is the President and CEO of IMA World Health. He will be moderating the next panel. He is a very passionate supporter of faith-based, particularly in Africa. IMA World Health works in several countries in Africa, particularly countries, even those in unstable situations, in crisis, supporting build health systems. So he has a lot of working experience with faith-based organizations, Christian health associations, in DRC, in Tanzania, in South Sudan. He collaborates with ACHAP for many years now. So it's really my pleasure to invite Rick to steer the next group of panelists. And we'll be better on your wisdom to see how you get us good to lunch in good time.
I'd like to ask the panelists to come forward. Jean Duff, Professor Miriam Wari, Rosemary McCullough, and Dr. Annette Thacker. Hey, good afternoon, everyone. Welcome to our panel. It's called Making the Case for Effective Health Programs in UHC. My name is Rick Santos. As Dr. Miranda said, I am the CEO of IMA World Health, and I will be the moderator for the panel today. I was informed that Dr. Thacker is not here, so the good news is we have both more time for questions, a little bit more time for remarks, and hopefully be done on time. Well, we've had some really amazing conversations this morning. We've heard the presentations have been really wonderful. And I think one of the things that they've pointed out is that there's many challenges in achieving quality health programs, and from a faith perspective and UHC here in Africa. There are multiple challenges of getting donors in sync with national ministries of health and getting both in sync with the needs of facilities and communities, getting them in sync with faith-based communities, not to mention building multi-layered, multifunctional health systems across each country. So today we're going to look at some of these challenges. In particular, we're going to look at some of the challenges affecting health programming from actually 3 perspectives. Each of the panelists will have about 15 minutes to talk about their topic, and then we will, after that, we'll just open it up for questions. So the way I'd like to handle this is I'm just going to do the introductions of the person speaking, and then when they're done, I will introduce the next speaker. So this afternoon already, I'd like to introduce Jean Duff. Jean, and actually everyone, I have bios for everyone, and to be honest, if I read their entire bios, we would be here the entire time, and they'd have no time to speak. It's a very impressive group of people. But Jean has been, she is the president of the Partnership for Faith and Development, and this is an organization that supports faith groups in their work with governments, with international, public and private sector, and it basically addresses the impact of local community health and development issues. Jean is the coordinator also of the Joint Learning Initiative on Faith and Local Communities, which is an international knowledge management platform for evidence for faith groups, activities, and contributions in community development and well-being. Jean also was the co-founder of the Center for Interfaith Action, or CIFA, as part of the Washington National Cathedral. And she is also the convener of the Global Initiative on Faith, Health, and Development and international collaboration to advocate for full inclusion of faith-based assets in development. So Jean has a wonderful background in this, and without taking any more of her time, Jean Duff, please give her a hand.
Thank you so much. Hello, everybody. What an honor to be invited here. I remember Sue Carey's remarks yesterday at the beginning of the wonderful seminar that she and Sue organized on Ebola and HIV, recognizing the extraordinary wisdom in the room. So now, having spoken to many of you, I'm even more humbled by you listening in the room. Dr. Komarogo, your presentation was absolutely fantastic and a wonderful precedent to my topic. I think we all know that the secret weapon to engagement for faith-based groups with governments is evidence. And I'm privileged today to speak on behalf of the Joint Learning Initiative on Faith in Local Communities on the topic of evidence drivers for effective partnerships between faith groups and public sector. A word perhaps about that slightly odd term, faith groups. We all argue all the time about our terminology. I use faith groups rather deliberately, and the illustrations are also intentionally chosen to include both the facilities and the faith-based hospitals and the faith-based healthcare delivery systems, but also the very important faith-based and religious networks that are such powerful influences for health-related attitude and behavior. Next slide, please. So I'll talk today, just in brief terms, I wanted to tell you about a very exciting invitation that I witnessed at the World Bank last week, and to set that in the context of brief remarks about the international developing world, some of which has been already well addressed, and I will move fast through. I want to talk about the implications of that for faith groups and partnering, strengthening their partnerships with the public sector. Tell you a little bit about the JLI, the Joint Learning Initiative on Faith in Local Communities, and to underscore that it is a way and a process, and by no means the definitive answer on evidence, but one that may interest you, and then to come to some recommendations. Last week I was very privileged to be in attendance, and I think what must be a historic meeting at the World Bank. Jim Kim spent almost 4 hours with international faith leaders, laying out the bank's twin goals of boosting shared prosperity and making the case for the doability of the second goal, which is ending extreme poverty by 2030. Now the bank defines extreme poverty in terms of the low number, living on $1.25 per day, and sets a numerical goal of bringing down the 1 billion or so people who are still living at that level, about 14.5% of the world's population, down to about 3% by 2030. And lays out a very strong case for the doability of that goal. One of the interesting things that I took from the meeting, and which we haven't actually heard yet in the excellent presentations today, is the whole notion that the investment in health is actually an investment in the economic growth of the country. And he quoted the important work of the Lancet Commission, that was led by Larry Summers, showing that 24% of economic growth results from better health outcomes. So the two are enormously intertwined, and we need to rethink our investment strategy as opposed to our funding strategy in that regard. So, in terms of the message to our community, President Kim was extremely active and passionate in calling first for a global movement around the twin goals. He called for solutions big enough to the challenge. He underscored his personal commitment to the preferential option for the poor. And as you may remember, he recently met with the Pope to discuss their common interest in that. And he seems very serious about that as a values paradigm, faith-based values paradigm. He calls for country-level full engagement with the faith community. And most interestingly, and why I'm underscoring it in my presentation today, insists, as he does, I think, in his leadership throughout the bank, and as his colleagues do as well, insists on a strong evidence-based framing for any partnership with the faith group. I can direct you on the JLI website, you'll see the address shortly, are the documents from the meeting, and I would direct you, those of you who are interested, to some more information about this meeting. This is a very important encouragement to our discussions here today, and to an interesting context for some of the even presentations we've just heard. Echoing Dr. Custodia's focus on universal health coverage, I just would like to underscore again, if I may, the complementarity of the focus on prevention and community-based care alongside the necessity of improving facilities-based and treatment piece, and just to highlight it there for us to be reminded of. So in terms of the international development trends, as a framing for partnerships between public sector and faith groups, we see a move to community-based integrated healthcare. As we've heard, further gains will come from advances in prevention. And the faith community is ideally positioned to have a huge impact, and perhaps I would argue uniquely positioned in terms of its potential influence on key health-related behaviours. This will lead to, this emphasis on prevention will lead to a priority on health-related attitude and behaviour change. And again, the scaling up of faith-based influence and community-based networks is so important there. The trends suggest a scaled-up priority to evidence-based, locally adapted health solutions. The funding, as we know, is favouring local partnership. It's interesting to see some sharper teeth coming into some of the guidance from multilateral funders in relation to requiring governments, national governments, to have a more explicit engagement of faith groups in their discussions. Global Fund would be one to look at, where we are seeing now a new round of instructions that call for, I think, still inadequate, but definitely stronger engagement. And certainly, I think we would, as advocates in the faith community, we should continue to call on multilaterals to strengthen those requirements of national governments to get us to the table. Ebola certainly highlights the twin necessity of both faith-based health system strengthening, but also accessing, mobilizing, and equipping local faith communities. And perhaps we will really have an opportunity to take these twin lessons from the response to the crisis and many of the challenges in the response to the crisis. We've seen a priority on equity, and the Sustainable Development Goals are framing goals around equity, and a priority for reaching and serving those who are at the lowest income levels. And all in all, throughout these trends, we're seeing a renewed emphasis on effectiveness and efficiency, on evidence and value for money. So what does this mean for faith groups, and what does it mean for HAP members? It means that we really need to push even further than the excellent work that is already going on, and I've learned so much from many of you in conversation. We need to push further to document both our facilities and our congregational assets and health outcomes. If we can go to governments with a clear and current picture of both the activity, the capacity, and the difference that we're making, we'll be in a much stronger position to get some MOUs that actually make sense. We need to look to collaborate across denominational and faith lines to deliver large-scale capacity. Governments don't want to work one by one. They don't want to work with singular faith entities. They need to be working with blocks and sectoral bodies, such as the Christian Health Associations, or even more broadly, multi-religious associations where that's possible and relevant. The opportunity, certainly, there's a very strong opportunity, I think a wonderful development for the HAPs, or the CHAs, to push out the partnering between faith-based health systems and with their local faith leaders on social and community mobilization for prevention and emergency response. The boards of all of the CHAs and the leadership of the CHAs already involve the senior faith leaders in your communities, and many of you are already engaged in social mobilization at a very significant scale. So there's a real opportunity, I think, to push that out to respond to the international development trends. We need to demonstrate outcomes for the poorest of the poor. Very often the Christian Health Associations have an advantage in rural care and in care to those of lowest income. We need to actually show that in terms of our data and our evidence. We need to hold public and private partners accountable around even a range of the issues that we just discussed. And we need to make a collective evidence-based case to governments for faith-based delivery and community outreach. So to turn to the Joint Learning Initiative on Faith and Local Communities, which has perhaps a share of some of this work. As Rick said, we are an international collaborative knowledge management platform, collecting and sharing evidence for faith groups' activity and contributions. The goal is to increase, the goal is through collaboration among policy, practice, and academia to work towards the fullest possible engagement of faith groups in community health and development. And we believe obviously strongly that evidence is a fundamental tool in that engagement. We ask several questions. We ask, what do policymakers and practitioners want to know? What do they need to know? We ask, what are the evidence drivers for effective partnerships? We ask, what do we already know? There is much evidence already in place, but perhaps it's not communicated well. We ask, how can it be better communicated? We build on a methodology that was developed by Jeff Foster from Zimbabwe. Around, many of you will know his work on the Joint Learning Initiative for Children Living with AIDS. It's a joint learning hub-based methodology. The steering committee consists of policymakers, academics, and heads of faith-based organizations. And I'm delighted that Sally Smith and Rick Santos and Jill Olivier, all of whom serve on the steering committee, are here to represent the JLI as well. Currently our work proceeds through 5 international learning hubs, one in resilience, immunization, sexual and gender-based violence, HIV and maternal health, and capacity building. And I'll just lightly go through these. The Learning Hub on Resilience, which is co-chaired by Helen Stafsky and Alistair Agar at Alistair's at Columbia University, asks what is the impact of faith groups in promoting individual and community resilience in humanitarian situations. They've been, under the auspices of the Hub, very interesting research is being carried out looking at the role of local faith communities in strengthening resilience among Syrian refugees in camps in Jordan, for example, and documenting the unique and powerful role of local faith communities. These things we understand intuitively. We know that faith communities are first responders in disasters. But in fact, there's very little evidence when it comes to a dialogue with UNHCR, for example, and they say, show me. They say we have difficulty engaging with the faith community. We have to be much more evidence-based in our response in those dialogues if we're to be taken seriously as partners. Sally Smith and Azar Karam co-chaired the Learning Hub on HIV and Maternal Health, which asked what are the activities and impact of faith groups on HIV and maternal health. And the scoping study, which is also on the website, and I recommend it to you, really supports the notion of the holistic delivery of care. That faith groups involved in HIV are also working in support of maternal health, and particularly the prevention of mother-child transmission of HIV. Jill Olivier has led the most magnificent, really the most beautiful piece of work that again I commend to you, the most current review of what faith groups are contributing to the acceptance and delivery of vaccine and immunization. The review and the annotated bibliography is available there. All of you are engaged as faith-based organizations in supporting vaccine, both acceptance and delivery, and it would be of great interest to further strengthen the evidence for the campaigns that you participate in, and to be able to produce that in your conversations with public sector organizations. There are 74 members and growing of the relatively newer Learning Hub on Sexual and Gender-Based Violence, which is co-chaired by Vino Sullivan and Liza Lutz, both based in South Africa. They ask what are the activities and contributions of local faith communities in the prevention of sexual and gender-based violence and the care of survivors, and are supporting an international movement to create safe spaces in the mosque and in the church for these issues, and to equip and mobilize faith leaders to do their part. The final hub that's in place now is a more cross-cutting hub that looks at capacity building for local faith communities. So many international organizations and nationally based entities such as yours are working hard to strengthen the capacity of faith groups to care for local communities and to collect and communicate data. This Learning Hub, interestingly, hosted a wonderful presentation by Channels of Hope. I see Darlene there. Recently, reaching out to across faith lines to all of the members of the Hub, who would include Islamic Relief and Salvation Army and the Anglican Church and a whole variety of various groups. World Vision reaching out with its Ebola training capabilities, which some of us were privileged to hear about yesterday, for new partnerships and bringing through the Learning Hub, bringing the capacity forward in that area. So here's the website address, very simple, jliflc.com. We'd be delighted if you would like to visit the site. Looking ahead briefly, there are 2 new hubs coming online, one in child health and survival, and one in peace and conflict. And perhaps you will help us imagine another one or 2. We're very much a learning network ourselves. We are not an institution. We are at best a very imperfect process, but a joint learning process. And we would welcome discussion from you about areas of your own interest that could coalesce into a hub. We're helping to organize an important conference in July, which will complement the World Bank invitation that I just described to you at the beginning of my remarks. This will be a conference to be hosted at the World Bank in Washington on effective partnerships between public sector and faith groups towards ending extreme poverty. Co-hosts for the conference will be USAID, DFID, the German development entity, and other partners as well. What an extraordinary opportunity for us to bring forward, and I really rely on you in the room, for us to bring forward the very best evidence to the policymakers who will be assembled at the World Bank for what we do and how we do it, and for how it is that we would like to more fully engage and more effectively engage with governments. So I will rely on you to assist us in thinking through what are the best stories and the best case, the best data to bring forward to this meeting. It's a really unique opportunity coming on the heels of the President's, Bank President's invitation. So In closing, our invitations to you, we invite you to join learning hubs as you might be interested in the different themes, and to consider perhaps leading a new learning hub. To work with us to exchange information on what works, what doesn't, very importantly what doesn't. I think we're just as credible in the evidence game if we talk coherently and in a disciplined way about what doesn't work, and if we show that we're willing to learn from that. And finally, we hope to have African Christian Health Association platform participation in the July conference. Recommendations, in summary, if I may, to the group, echoing Jim Kim's word, solutions big enough for the challenge. The collective might and power in this room is certainly a solution big enough for the challenge. The question is, can we get this taken seriously? Can we get seen as the collective force that is represented in this room? And can we make a collective case? So three areas of recommendation in summary. Work hard to continue to improve the evidence base, share knowledge, look to forge new research partnerships with academia, with folks like IRHAP, represented there by Jill Olivier. Scaling up faith group collaboration, exploring innovative ways to collaborate across denominations and across faith lines to strengthen the collective voice. Partnerships between facilities-based organizations and faith communities networks, and intentionally equipping and mobilizing local faith leaders and communities so that they can do good work at the grassroots. Finally, making the case to the public sector, authorizing collective representation. Again, the faith community governments have difficulty dealing one by one. Organizations like the Christian Health Associations are important collective voices. Do they need to be expanded to be fully inclusive of other religious groups? And would that be effective in some cases? Aligning with national plans very intentionally, which of course many of you now do. And focusing on evidence, how faith groups deliver outcomes, particularly for people living in extremely low incomes, but not exclusively. Great. Thank you so much.
Thank you very much. It's a wonderful presentation, and we're going to move on to the next one. I know we have a little bit of a time press. So I would like to introduce the next panelist, Professor Marian Wari, who will discuss community health systems to bring effective health programs and services to every household. And I have to say I'm quite honored to be on the same stage with Professor Wari. She is really esteemed person in Kenya, and her body of work for her career is amazing. Just to go quickly over her bio, she has a degree of biology and chemistry and physics from William Penn College in Iowa. She did some postgraduate. She did a postgraduate diploma in education from the Makari Uganda University, where she taught secondary schools in Kenya. And then at another point in her life, she decided to study medicine and has a degree from medicine from the University of Nairobi. Now added to that, she also has a degree in public health from Johns Hopkins University School of Public Health, and she has both a master's and a doctorate from Johns Hopkins. So it's really an amazing history and academic career. She has worked throughout her time here in Kenya in a variety of things. I don't want to go into everyone because it's a very long list. But just to say that in her career in health services expansion and research in Kenya and in other countries, she has focused on community health approach, both within the public sector and in not-for-profit organizations. And just to say, she's been honored many times, and most recently she was honored, designated Kenya's Community Health Strategy Goodwill Ambassador, a title that she holds today. So please give a warm applause.
Thank you very much, Bruce. As you have been told, I'm going to speak on the role of community health services in creating effective health programs towards universal health coverage. Now, a lot of us know about community health programs, community-based health activities, and the challenge that usually comes to us is the challenge of knowing what we mean. Many times people don't take community health seriously, and they usually say, oh, those people sitting under the tree talking about some things about washing hands and latrines. And so, if we are an effective community health service, what should we expect? What should people expect? And I listed some things down that I think people should expect to, or we should expect if we are running effective community health services. One of them is that we should expect there should be good understanding of health promotion. If we are working in community health services, we should expect that our audience, the people that we work with, the community members, households, have a good understanding of health promotion, how to promote health in their lives. There should be good understanding of disease prevention, the diseases that are in their lives, how could they be prevented, which ones could be prevented, and being involved on communicable and non-communicable diseases. We should expect them to understand what good health-seeking behavior is. Now, what constitutes good health-seeking behavior? Our people should understand that in our communities, if they are going through successful, effective community health services. They should also understand the proper use of facilities. How do they use health facilities? Our people should also understand what it means to have compliance with treatment regimes. If a health professional tells them a particular treatment regime, what is the importance of compliance? This should be part of the information of the people who are working in community health systems. What are the referral systems, if there are any, or if there are none? If there are any, what would they be if they were present? And then there should be an understanding of the proper handling of social determinants of health. Which factors in our societies, in our communities, would help to promote health in our lives? What's the role of education, for instance, in promoting health? What is the role of food production in health? What is the role of good housing, water, sanitation? This should be an understanding that our people have if they are going through effective community health programs. And there should be a financing mechanism that supports the community health services, which is one of the biggest challenges that community health services have. So in such a community health service which is effective, there will be a lot of contribution towards universal health coverage. And the point I'm making is that if we establish effective community health services, we shall be establishing the foundation for national health systems. And that such a national health system would, in fact, provide universal health coverage. But in order to establish these effective community health services, I think that we need to be aware that there needs to be a structured approach to establishing community health services. That we think about it carefully and be structured so that it can actually become an effective community health service. So the goal
What should be the goal of community health services? The goal is to bring basic health services to every household. We had the director said this morning that we shouldn't be concerned only with basic health services, we should be concerned with comprehensive health services. But what we have found is that at the community level, if you begin with basic health services, you are doing well, on which they can then subsequently build, so that health is brought, the concepts of health, access to health, is brought across the community, both physically and social-culturally. We have found in some of the research we have carried out that people living next to a health facility don't necessarily use the health facility. And why? Because of the social-cultural distance between the health facility and the health and the people. We have found that you can have a very good health facility in a country, but if people are very far from it geographically, they don't benefit from it. So the goal is to reduce the distance between the facility, the modern health services, evidence-based health services, and the people, both physically and social-culturally. We should have a clear vision, and that clear vision should include that we are talking about people living healthy and good quality lives in households, at the household level, in robust communities, so that people are living healthy lives, good quality lives in healthy communities. We should have a clear vision being that the vision should be that we are actually using the community health approach as a means to establishing holistic development. Because as it has been said, if you can improve health, you can improve the economic development of the situation. And if you are improving the health of the community, you can have holistic development, especially since you have to deal with determinants of health when you are dealing with these things at the community level. And one of the important findings that we have seen in our work in communities is that if it happens at the community, it happens in the nation. And if it doesn't happen at the community, it doesn't happen. So investing in communities is not wasting time, because if it happens in the community, it happens in the nation. And if it doesn't happen at the community, it doesn't happen. So what are some of the organizational considerations that we should have when we are considering establishing effective community health services? One of them is that there should be a clear understanding of what our community is. We have found that there can be very varied discussions, very varied concepts about what our community is. And it seems that in every nation which is practicing community-based health care, there should be an understanding of what our community is. In Kenya, we had long debates over this matter. One group, one project defining it differently, another defining it differently, and eventually when the Ministry of Health became involved in community health services, we got to one definition. That is to say, we took the smallest administrative unit in the country, the sub-location, to be the community. This because if you say the sub-location, everyone understands what it is, and they can then relate to it because everyone understands what our community is. We have found this to be a very great supportive element in the work of community health services. A community defined as a sub-location means that there will be several villages in the community. In other words, a community does not necessarily equal a village, because in many countries, a village can be very, very small, 20 households, and if you divide the country into 20 household units, which are the communities, the numbers become overwhelming and they become rather difficult to work with. So the sub-location is about 5,000 people who constitute about 1,000 households. Although this is very different in various parts of the country because of the density population being variable in various groups. in terms of organizing community health services. Once you have understood what a community is, or you have agreed on what a community, what constitutes a community, then you need to have a community health committee. And this is not only a Kenyan experience, it is also an experience from other countries, Ghana, Rwanda, Ethiopia, that you need to have a community health committee which takes out the leadership in terms of leadership and governance oversight. Who decides, or when you have a meeting, who decides on the general things around which the community health activities are structured. Then you need to have a clear idea of community level health workers. Who constitutes the community level health workers? We have found that having a general information that is agreed upon in the country makes this very important. For instance, in Ethiopia, they have the health extension workers. In Ghana, they have the national tropical nurse. In Kenya, we have the community health extension worker or the community health assistant. So that there's an understanding in each country as to who leads the work at the community level. And when that is done, then there is clarity in terms of who is heading the work at the community level and what kind of work does it happen. What kind of work should this leader provide? Then at the same time, you have other people who are working with the community leader in terms of community health leader. And we have found that community health volunteers are very important. Community health volunteers used to be called community health workers, but in most cases, these are not people who are paid. Community health extension workers are members of the government because they are trained in formal training and they just become engaged at the community level. Community health volunteers are not formally trained, but they are trained in terms of being given information, and their main role is to keep contact, close contact with the households. So you'll find that in community health volunteers, they have been trained in preventing ideas of preventive medicine, health promoting medicine, health preventive ideas, and they are trained in communication skills, how to support the households. And in most cases, you find that the community health volunteer is representing or coming from a village, so that you have either 10 households or 10 households who the community health volunteer comes from. And the community health volunteer then is the one that is in complete contact with the community health, with the household. And therefore the community health as extension worker or the community health community extension worker is in touch with the community through these people. In Ethiopia, they even call it the community health army. So that these community health volunteers become the main contact between the community and the people. So you need to have, you cannot have an effective community health service unless you have got a clear idea of who the community level health workers are going to be or are. In some countries, there is the community midwives. The community midwife is also a trained midwife who is engaged at the community level. And this is popular, especially in those countries where we still have high maternal mortality rates. So that the community volunteer midwife provides services at the community level. The community midwives can provide these services in terms of antenatal service care and making sure that the expectant mothers go to deliver in health facilities. And if the health facilities is very far, the community midwife helps the family to have a bad plan in terms of Where will she deliver when the time comes? And how will she get there? Does she need to go in advance? Or does she need to go ahead of time? Does she need to go a week ahead of time, or how far in time should she go to the health facility where she will deliver? It has been shown in the literature that community maternal mortality is not very much reduced when the delivery takes place at the village level because of the complications of deliveries, which cannot be handled at the community level. So it is useful to have a maternity, a community midwife who can advise the expectant mother on antenatal issues and also on birth planning so that they will know where to go to deliver their baby. If you're going to have community health level workers, then you need to have a curriculum. And the curriculum then is planned in a different way. For instance, the curriculum for community health volunteers can be more basic, can be quite basic. In the Kenyan setting, we have two groups of curriculum. We have the basic introductory modules of the curriculum, which among them is an introduction, the idea of health and development. What are the links between health and development? And out of these basic modules, we have 6 basic modules through which we train community health volunteers. Then the technical modules talk about integrated community health care, community-based health care. For instance, what are the community health, what kind of services can be provided at the community level? Maybe something like malaria tablets can be given at the community level, because people can buy malaria tablets off the counter in the market. So they can be trained how to provide this very well. How to do water and sanitation and personal hygiene, household hygiene, so that there should be a clear curriculum in terms of how to provide for the community health volunteer. So that although the training is flexible in terms of the actual delivery, it is in any case structured. It is structured in order to provide health facilities, health services that can be good quality. The community training for the choose for the community health extension worker is more formalized and usually takes a year. What the other one takes 2 months at a time and it takes 2 months at a time and it can take two weeks at a time, and then the community volunteer goes to work and then comes back later. The community health extension workers curriculum is more structured and more professionalized. So the important point we can make in this time that we have is to say there should be a structured curriculum that is clear to everybody and clear to the people. Then, in all this, for instance, among the community health extension workers curriculum, there will be topics on facilitating supervision and monitoring, evaluation, and reporting, because this is one of the duties that we carry out. The community health extension worker supports the work of the community health volunteer, and they supervise the community health volunteer. So this one helps them to understand how to do the supervision and how to do the monitoring. When we have done the basic understanding of what the community is, what the community health community is, what the community health workers are, during this training, we are also making it clear what kind of support the community level is going to be receiving. And this is the level that usually the formal government usually lets down the community level, because usually the help that is needed at the community level is not often forthcoming. But I'm happy to say that in a country like Ethiopia, the help is very structured from the formal government. Also in Ghana and in Rwanda, the help is very structured from the formal government to the community. In Kenya, it is very good to see that the county governments are are very keen on stepping up the training of the establishment of community health services so that they can provide the kind of support that is required for the community health service to be vibrant and robust. And finally, there needs to have standards for community health service. For a long time in Kenya, we didn't have standards for community health service. But now, standards have been established. And these standards help to know what to look for. So if you have a general curriculum that is being rolled out in the country, but how do you know how well it's being rolled out? So the standards become very important in terms of the quality assurance and quality control. And this way, you can know exactly what kind of quality is being delivered, what kind of quality is being delivered, and how is it being delivered. This also allows the health worker, who is the overall supervisor, to have a good idea in terms of what is happening in various parts of the country. Is the health facility, is the community health services being carried out as well in one area as well as in the other, or this one area not doing as well? Is the community health service improving or deteriorating over time? So that when it is over time improving, we can know how to make it work better. So standards are very helpful to develop because you can establish a framework for comparison over time and for comparison between communities. And you can establish this as a basis for learning, communities learning from one another. If one is doing particularly well in one area, you can invite them to go to another community so that they can learn from that community. And they can help learn from one another in various areas. Another item which I think is the final one is the client satisfaction. Sometimes you can go to a community health service where it says a matter of giving orders. But fortunately, if it says a matter of giving orders, usually it doesn't work very well. And because we go back to the definition of health, and the definition of health being health is a state of physical, mental, and social well-being, and not necessarily the absence of disease or infirmity. So always at the back of the mind should be that, are the people enjoying this, what we are doing together? Are the people happy about it? Are the people involved in discussion? And that's why it is important to establish community dialogue sessions so that people can actually take part in the discussion, community action sessions, so that people can be informed in carrying out some of the tasks together as a joint activity. So if we can actually do this as a way of making the people enjoy themselves as they learn, it becomes a very strong point for improving the community health service. Because if it happens at the community, it will happen in the nation. And if it doesn't happen at the community, it will not happen in the nation. What I would like to commend this group is that faith-based groups which are in one area, but from different denominations, it seems to me that it would be a good idea as a way of, because most of the community health work was begun by faith-based groups. It would be a good idea for the groups which are in one geographical area, in Kenya, I can say in the county, or in the region in Ethiopia, or in the province, to come together and say who would be responsible for which community. Because our faith doesn't go geographically, but we can still provide services in terms of geographical code. And this area can be provided health facility, community-based health services by the African Church, and that area by the Chapel Church, and this area by the Methodist Church, so that the communities are covered. And I think that if the community, if the faith-based groups take that kind of approach, we can really contribute to universal health coverage. because we can make sure that every community is covered. And we are covering everybody so that nobody is being left out. And I think that if we can do that in an organized way, then it will add our voices together when we can have negotiations with the government and with the external bodies like IFC or World Bank, so that they can support what the churches are doing. All the time I was growing up in the 1940s and 1950s, all the facilities that were there were from the church. There were none other. Just like the schools, they were from the church, working at the village level. So I think the church has this experience, and the church has a particular strength of working with the community health service level, as well as at the first referral level. So that as you work in the community, you develop the first referral level, what in Kenya we call the link facility, so that they become the referral center for the community, and they become the supervisor of the community. So I believe that in this area of universal health coverage, the church has a lot of potential and a lot of opportunities to actually contribute in a very substantial way to universal health coverage. Thank you very much.
Thank you, Professor. Our last speaker is Rosemary Amuru. She will be talking about domestic health financing from a global fund and Gavi perspective, and in view of both the recent Gavi replenishment and the global fund replenishment upcoming, and those investments, and those successful investments in the health system. She's going to talk about how governments now, for this to be sustainable, need to up their own game in terms of domestic financing. A little bit about Rosemary. She has over 10 years of international experience in areas of public health research, program, and advocacy. A civil society organizer who has extensively worked on building and strengthening civil society networks and platforms on HIV and AIDS, health advocacy, and campaigns in Africa. Rosemary coordinates the Global Fund Advocates Network, and she works for the World's AIDS Campaign and hosts the African Civil Society Platform on Health. She also, I just found out today, as with me, sits on the Gavi CSO Steering Committee. She holds a Master of Public Health from Ohio University and a Master's in Business Administration from Frostburg State University in Maryland.
Thank you. Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon.
I think I need more energy. I have the honor of speaking just before lunch or just after lunch, so I know I definitely have your undivided attention. So I want to appreciate Professor Robo's presentation. The spirit of his presentation will continue to be reflected in my presentation. The main backdrop of my presentation is the Global Fund's faith replenishment, as well as Gavi's replenishment that just ended in January, actually launched it in January. And within that context is to acknowledge that those of us from Africa, we are categorized as implementing countries. If you look at the Global Fund and the way the things are divided up there, we have the donor countries and we have the implementing countries. So then I guess we are primarily concerned with how we as implementing countries get the resources to implement the different interventions that we have. But rarely do we take time, maybe we do, maybe we don't, to think about then once we get the money from the Global Fund or from Gavi, how do those institutions then replenish those funding awaiting for the next allocations? So basically it's to look at how do they get replenished, and is there a role within that replenishment for domestic resource mobilization? So the presentation will be highlights from the Global Fund's domestic financing strategy in the context of resource mobilization. And just to clarify that when we talk about domestic resource mobilization in the context of the Global Fund, we are not talking about implementing countries or African countries or national governments putting money into the Global Fund. That would still be nice and I think appreciated, but within the Global Fund strategy for domestic financing, and it is the same strategy for Gavi, for domestic financing, is really to call upon African governments or national governments of implementing countries to invest in their own countries in health. So this is all premised on the realization that donors cannot do it alone, and that we have heard increasingly now donors calling African governments or implementing countries for that matter to take up more ownership in the responses, to take up more ownership in financing or investing in the disease programs that we have. And that ultimately is geared towards sustainability and predictability of financing. Next slide, please. So what is the Global Fund doing at the moment? It's working with countries and partners to leverage on the Global Fund resources. This is to encourage increased government commitments to disease programs and related health system strengthening. We do know that in accordance with the policy on counter-financing or counterpart financing at the Global Fund, applicant countries are required to demonstrate that government contribution to the national disease program reaches the counterpart financing threshold. And that is different for different countries, depending on whether you are low-income country or low-income country or upper low-income country. The other thing the Global Fund is doing is to improve data quality and accessibility for both domestic and international health funding, basically working with the Global Fund country teams and the Treasury and the different groups involved in determining that to improve the data quality and accessibility of those, either by the ministries of health or other sectors in the country, as well as civil society. The other thing is to identify and address rigid budgeting practices, allocative inefficiencies that are obstacles to the reallocation of revenues towards health. One of the things that happened with the Global Fund when the Ebola crisis came up in Liberia was that the Global Fund was able to reallocate some of the financing that had been budgeted for certain interventions, and looking at the emergency at hand, there was ability and flexibility to reallocate those revenues. And so why would the same not happen at the country level, that flexibility for certain times? The other thing that the Global Fund Secretariat is doing is to foster effective dialogue between local health and finance officials. We realize that the relationship between the Ministers of Finance and the Ministers of Health is not necessarily or always one that gets us to where we want in terms of more money for health. And so working on that relationship. Last year, the Global Fund, together with the African Development Bank and the African Union Commission, convened a summit for the African Union Ministers of Health and African Union Ministers of Finance in Addis. And in that conference, they had prioritized the Global Fund's priority countries. There are about 8 countries in Africa, and none of the Ministers of Finance showed up at all. So we just had a conversation and a dialogue with Ministers of Health. So really not a dialogue, I guess they were speaking to themselves. And then also supporting countries in establishing an acceptable benchmark on a country-by-country basis and discussions on innovative domestic resource mobilization tools. Now, we know Africa has made commitments. For us, on the civil society side, when we engage in advocacy on domestic financing, calling the government to increase funding for health, we've always used the Abuja Declaration, 15% as a benchmark. But what the health economists are telling us is that we are probably maybe wasting our time if we benchmark with the 15% Abuja Declaration. So the more progressive and productive way to go is to take country by country scenario and to see how much can that country, what are the opportunities within that country, what are the different dynamics in that country. Some countries could perhaps even do 15%. So there's an ongoing discussion to help countries set their own benchmarks. Then there's a whole discussion around nurturing political leadership. So when the Global Fund engaged in the fourth replenishment campaign, they engaged African leaders as champions. So we had African heads of states, we had African first ladies who championed the Global Fund replenishment, and that is something that is still going on for the fifth replenishment. And then also, the Secretariat is working to revisit and raise awareness on economic arguments for health, including how it makes macroeconomic sense. So really looking at the different business cases and economic cases for why should we invest in health. And of course, supporting the universal health coverage discussion within the post-2015 agenda. So this chart basically is to tell us that everybody is on the table, looking at Global Fund's advocacy model for increased domestic financing for health. So it's really talking to the decision makers, that's the heads of states, the ministers, and then there are different stakeholders from different sectors that are involved. There is a box for NGOs, and I want to believe that is where the faith-based organizations will fall. So I guess the question and the challenge for all of us is to say, are we at the table when these decisions are being made, when the discussions are being made? I know Dr. Mweda is at the KCM, so maybe that's just one voice, but it's also a question of how we engage in communication, feedback, and consultation, and how we can support his role, for example, in that position. Next. So some key challenges, three of them, they've already been mentioned by those who spoke before me on domestic financing, value for money. As the resource landscape is changing, focus is now more on health efficiency and effectiveness, which calls for both more money for health and more health for money. Domestic advocacy, a large part of any increase in public funding for health will need to come from governments. Therefore, they need to develop a convincing business and advocacy case for increased or sustainable public commitments to programs. So that really just speaks to us as organizing ourselves within the health sector to make a convincing business case or economic case for why more money for health. Sustainability in terms of domestic public spending should continue as economic growth continues. And basically we are saying that we are not saying that we need domestic financing to replace external funding 100%. There is a transition process, but governments need to start taking ownership at the moment. Now is a great time to do that. These have been mentioned. When we did our campaigns and advocacy previously, calling African governments to increase domestic financing in health, we kept pushing the governments to increase to 15%. But we really never had a conversation of, well, what are the different sources of the 15%? What are the different new innovative ways that governments can use to raise resources? So this has been mentioned, the air levy, different 2% of public sector budgets earmarked for HIV, mobile phone levy, etc. Next slide. So areas to work on. So what does all this mean for us? What this means for us as people working in the faith-based sector, responding to health in different countries in Africa is that number one, if you are going to call our government or to succeed in seeing an increment in domestic investments in health, we are going to need to recognize and improve the role of civil society. Our role as civil society, our role as FBOs, our role as non-state actors in demanding. Because the demand side, we have to work on that and to use facts, to use evidence, to use economic cases to do that. So we need to recognize that. And one of the things that Gavi has done, it has an approach on engaging faith-based organization. And within that approach, there is an advocacy strategy that has 4 pillars that faith-based organizations can capitalize on. Gavi is looking more at outreach, partnerships, country engagement, and information. And so there's a space. There's a platform that we can take advantage on and engage more with Global Fund, engage more with Gavi. Then we need to address the core question. Is it possible to define the right mix of domestic and international investment in any country? This will vary from country by country, but in terms of taking ownership, in terms of working towards sustainability and predictability, we need to look and find what that right mix is. And finally, establish on a country-by-country basis an acceptable benchmark for countries to invest from their own resources. At the moment, we are working on a 2-year campaign with civil society in Kenya, in Tanzania, and in Senegal. And the biggest challenge is, what is our ask? How much of an increment should we ask the government to put into help? And Kenya is especially, the dynamics are really, can be challenging in setting that benchmark because of the resolution. So you really don't know exactly what you want to ask for, because you can't ask for a blanket benchmark for all the counties. So there's need to look at county by county, case by case, and then to look at the different functions. The national government has its own functions, the county government has its own functions. And that's just one example of the challenges that countries experience. I would like to acknowledge the Global Fund. So this presentation was mainly informed by the Global Fund strategy on domestic financing. I work for the Global Fund I am a member of the Global Fund advocacy network. It's called GFund, that works closely with the Global Fund Secretariat on Global Fund resource mobilization, which now includes domestic resource mobilization. I want to acknowledge Linda Mafu, who is the head of political and civil society advocacy at the Global Fund, for her technical inputs in the presentation. And I also want to acknowledge the Global Fund Advocacy Network that is supporting civil society to align to domestic financing advocacy in light of the faith replenishment. Therefore, in ending, as faith-based organization, there is an opportunity for us to join hands as civil society and to engage in a coordinated civil society response towards ensuring that there's increased investment at the country level through domestic resources. Thank you.
Thank you, Rosemary. In terms of timing, is there time for a few questions, or should we ask Sam? I think the other option would be, if we go to lunch, that if you want to speak to our panelists individually, one-on-one, and ask them questions, you can do that. So let's just say a round warm of thank you and applause for our panelists. For Jean, highlighting the real need for evidence and evidence-driven interventions, and the faith community needs to be better at that. For Professor Wari, for talking about the need for really a community health approach and community health system, and then of course Rosemary for her talk about domestic health financing. Again, thank you very much. Is there announcements about lunch?